Very good morning, everybody. Welcome to our 25th educational webinar from Rumah Sakit Binawaluya. It's a very special day today because we will discuss about the distal radial interventional technique for you. And it's a very exceptional day today because we have an exceptional speaker and also the intervention. And I will introduce our speaker today. You will know that Professor Ferdinand Kimene. He is a pioneer of radial intervention in the world globally and spread all over the world about this radial intervention. And also he a pioneer of the distal radial technique. Please welcome Dr. Kimene. Good morning, Doctor. Nice to have you here.
My pleasure.
And also, we have also a pioneer for radial intervention in Indonesia, who is a legend in interventional cardiology in Indonesia, Professor Dr. Munawar. Please welcome Dr. Munawar. Hello, Dr. Munawar.
Hello, welcome.
Yeah.
Welcome. Thank you very much, Dr. Benny.
Dr. Munawar also the pioneer of radial intervention in Indonesia, and we are very happy now to have him here. And also, he will do some case today with distal radial intervention. Okay, without further ado, I will introduce the Professor Kimene to give the lecture for all of us about the distal transradial intervention, the rationale and the evidence. Please, Dr. Kimene.
Thank you very much, Dr. Hartono. Thank you very much for having me here, and congratulations with your 25th anniversary of this educational program. Okay, I'm happy to inform you about the backgrounds of distal radial here, the rationale and the evidence so far. It's a young technique. I think distal radial access can be considered as a refinement of conventional radial procedures, and I'm happy to explain you how and why. More the why than the how, actually. So let's start with the rationale. Before actually giving you more detailed information, it's good to know what I'm talking about when I talk about distal radial access. There are two locations, one proximal to the extensor pollicis longus tendon in the snuffbox, and you can access the radial artery even more distally beyond this tendon, which is also called dorsal or distal access. Both entry sites have different characteristics. My personal preference is puncturing in the snuffbox. I will explain later, but very important is that the radial artery here runs very superficially on bony structures, while here the artery may dive deep into muscular tissue, which makes the artery, I think, a little bit more difficult to access and also to achieve safe hemostasis. But in experienced hands, I think distal radial access here beyond the tendon is a good alternative as well. But let me focus on accessing the snuffbox. Here, this is the part of preference. This is the traditional entry site, proximal from the superficial palmar branch, which originates a few centimeters more distal in the wrist. And this is the anatomical snuff box, and this is the preferred exercise here. The artery runs here over bony structures. There's a nerve running near the artery, a vein as well, and there are tendons. So it's a complex. It's a complex anatomical place actually, and you have to really be careful accessing this place. I think you have to puncture the artery with care. Personally, I prefer ultrasound, especially in the learning curve, because of the complexity of this snuff box. And this is the dorsal or very distal access place where the artery runs over muscular tissue. The distal radial artery is a bit smaller in diameter than proximally, also in Asian people. And another important feature is that there's an extra curve here. Especially in the elderly or in patients with arthrosis of the hand, the artery may make two angles, one here, one there, even up to 90%. So that explains some of the complexity of accessing this site that you need to be aware of. Here, this slide actually comes from the consensus report of the first Korean European transradial intervention meeting. It's from a paper published in JACC Interventions by Dr. Guelja and colleagues. Summarizing some of the anatomical characteristics, the hemodynamic features, and also very nicely summarizes some of the procedural benefits, like comfort for patient and operator, easy and achievable access in patients with limited arm motion, a reliable and safe compression because of the superficial course of the radial artery running over bony structures. Catheter handling is actually quite similar compared to femoral access, especially from the left side. And very important, it preserves the forearm radial artery patency, because the radial artery in many patients is used more than one time. So we need to be very careful handling the radial artery and preserving it for future use. I will discuss that a little bit later in this presentation. Yeah, this is, I will explain in 3 slides why radial artery occlusion rates are so low with distal radial access. And this is a very important study from Rotterdam, the Rotterdam Radial Access Research Group. They published an ultrasound-based radial artery evaluation for diagnostic and therapeutic procedures. They were using high-resolution ultrasound. And what you can see that on all levels in the forearm radial artery, there are possibilities that the radial artery gets damaged. Sheath insertion and sheath removal in this upper panel might create intimal tears. There can be, due to puncture trauma, dissections can develop, intramural hematoma, pseudoaneurysms, spasm, and thrombus formation. All these actions here by us can result in early and late radial artery occlusion. So that's one. And by not having puncture trauma or sheath removal trauma or even hemostatic trauma in the forearm radial artery, of course, those risks do not exist anymore. Another important feature is that accessing the radial artery in the snuff box means that you puncture the radial artery distal from the origin of the superficial palmar branch, which runs here. That means that in case you have a distal radial artery occlusion caused by the same traumatic effects that I just showed in the previous slide, that there is still persistent flow through the radial artery via this superficial palmar branch. So this persistent flow also will lead to a forearm radial artery patency. Risk of thrombosis is very low. And the third explanation is that the superficial course of the distal radial artery over bony structures allows for very precise hemostasis and also very light hemostasis. So you won't have this prolonged and strong pressure required to prevent hematoma. Light and short compression will reduce radial artery occlusion rates. And there are other advantages for the patient. Here in patients with very obese arms, for example, the radial artery runs quite deep and might be more difficult to puncture, but especially more difficult to compress, which might result in forearm hematoma. And in a very obese arm, hematoma development is very difficult to recognize very early in its progress. While in the snuffbox, the artery still maintains its superficial course, and it still remains easy to compress. So this is a huge advantage in patients with considerable overweight. And then hand position for left and right radial artery approach is very comfortable for the patient, because the patient can just have the arm in a very relaxed position, don't need to supinate the hand to make it accessible for the operator. And the more so for patients with arthrosis of the shoulder joint, especially during left-handed cases, which is necessary quite frequently for many reasons. The patient does not need to bend over the arm to the operator, which really makes the position very relaxed. And the short hemostasis time and the free movement of the wrist after the procedure, and the comfort also for right-handed patients when you do a left radial approach, all add to advantages to the patient and comfort. And for the operator, there are many advantages. Of course, in case right radial access is impossible, you can do a left radial access easily for the patient, and now for the operator. Also, ease of Lima angiography from the left side is very easy, because the left hand is placed on the right side of the patient, at the right femoral side. So the operator works at a safe distance from the radiation source and does not need to bend over the patient. And it's therefore associated with more comfort for operators, especially if the operator is not very tall. So less back pains during long procedures. From the left side, there are no arteriolussoria problems, but that's a rare problem anyhow. There's less subclavian tortuosity. There is a lower risk for CVAs when approaching the coronaries from the left side. Like I mentioned before, natural route for femoral-shaped catheters. In case of radial artery spasm, in the forearm, you still feel a good pulse in the snuffbox because of collateral connections, which allows you to puncture the radial artery just as well, but now a little bit more on the proximal side. And it's even possible to open up occluded radial arteries from the snuffbox by a retrograde passage of a wire through an occluded segment. Here, this is the illustration of a conventional left radial approach where the operator needs to bend over the patient in the left part of the slide. creating back pain and significant radiation exposure. While with distal radial access, the operator stands at the patient's knee level, actually, far from the X-ray source, and it doesn't need to bend over, which is a more relaxed position. So these are some of the reasons that I thought was very interesting to promote distal radial access as a default technique, especially from the left side, because it has additional benefit. But of course, you can enter the radial artery from both left and right side. So my personal preference is to use the non-dominant hand, so the snuffbox of the non-dominant hand, so that the patient has the dominant hand free and the non-dominant hand is used for access. So how about evidence? Well, it is a very young technique, so evidence will take some time. Here, I just remind you that although the first radial artery procedure or intervention was done in 1992, it was only 25 years later that it became a standard guideline based on multiple studies and meta-analysis. We had the mortal study, the rifle study, the rifle STIAC study, and the matrix study. They all delivered they changed evidence into proof, and but that took 2 decades. So if we are talking about evidence on distal radial, we are still quite early. Here, one of the latest randomized trials is the Distal Radial trial, which is a very important study. It, although it did not reach statistical significance, the radial artery occlusion rates of distal radial access was extremely low, 0.3%, has never been reported before. And here with a patent hemostasis protocol and simultaneous ulnar compression in the forearm group, radial artery occlusion was also quite low, lower than expected, instead of the 3%, which was the basis of the statistical analysis and population calculation. It was only 0.9%. That's why the study was actually underpowered for demonstrating a statistically significant difference. But still, I want you to know that distal radial access here was associated with a 3-time lower radial artery occlusion rate than via the forearm. And here now we have data from the dTRA trial. It's a multi-center study conducted in Russia by the 3 pioneers and godfathers of distal radial access, Babunashvili, Khalidin, and Korotkik. And they compared radial artery occlusion rates as a primary endpoint after distal and proximal radial access. If you only look at the I'm sorry for my pointer, that doesn't work, but if we okay, here, if we look at the radial artery occlusion rates in distal group was 2.7% versus 6.8% in the forearm group. Maybe this comes closer to real life situation, but here the difference was very significant. And also significantly less BARC1 bleeding and hematomas. It is very important to mention. Also significantly different outcomes. And the price actually to pay is that the distal radial artery technique is more complex, more difficult, has higher failure rates, but still success rates are around 95%, so which is very quite high. you see the same in in multi-analysis. I can't get my next slide. Okay, this is yeah, there are quite some multi-analysis, meta-analysis performed, which all show the same. They all point into the same direction. Reduced radial artery occlusion rates with distal access, reduced bleeding complications, but higher crossover rates. And that's also with the latest meta-analysis that has been published in March this year, where 28 studies with over 9,000 patients were analyzed. Distal radial access resulted in shorter hemostasis times, reduced incidences of radial artery occlusion rates, very significant, reduced bleeding, also significant, and reduced pseudoaneurysm formation, also significant. But on the other hand, the negative side, increased access time and increased crossover rates. And I just want to mention here that a crossover from the snuffbox to a few centimeters more proximal is actually not a clinically and procedural relevant issue. It's important to remember that over 90% of your patients will have a successful distal procedure if you start distally in all patients. So 90%, over 90% of patients do benefit of the additional advantages of a distal radial approach. And our task is to get more proficient in the technique so that access time is reduced and that crossover rates are reduced as well. This slide also comes from the consensus paper by Sguelia and colleagues about the success rate. It is again somewhere over 90%, as you can see, and the big dots represent the larger studies. So this is actually this is the evidence today. And maybe it will take many years before the evidence becomes very solid or more solid and evidence changes into proof. What we could also show, and that is a very important matter actually, that is distal radial access safe? I just said in my introduction that we access the snuffbox, which is a very anatomical complex structure. But distal radial access is not associated with hand function loss. And we tested that with pinch grip tests, with sensory tests, and so on, and a 1-year follow-up. You can read this paper, the Ratatouille study, in the JACC Interventions, which was published last year. So distal radial access is safe. So what are my conclusions? Distal radial artery access is safer compared to forearm access. It reduces radial artery occlusion rates to the lowest level ever reported, but at the expense of increased access time, lower success rates, and higher crossover rates. I think that starting TRI conventionally in the forearm, you will miss a chance to offer the patient extra advantages like a reduction of radial artery occlusions, like increased patient and operator comfort by simplified hemostasis and reduced workload for the staff who is taking care of the patient after the procedure. So my message is to start a procedure in the snuffbox. This is my recommendation. Distal radial access really offers a valuable opportunity to refine and fine-tune TRI to the limit without detrimental side effects. I think this is a very important message, and don't let that chance go by, because you will offer your patient better service. And I think that the problem of lower success rates is a personal matter. You can increase your success rate by becoming proficient, do this on a routine basis, use the proper tools, use ultrasound guidance, especially early in your learning curve, and you will see that in the long run, you will become just as proficient as with conventional radial. Thank you very much for listening.
Thank you very much, Professor Kimene, for the very good presentations and very strong message that encourage us to start the distal radial interventions.
Great.
With very evidence of lower radial artery occlusions and also less bleeding. And the important thing is convenience for the doctor and the patients.
That's a good summary.
Thank you. Okay. We will have a discussion. I will remind the today agenda. After this presentation, we have discussion, and then we have a live cases performed by Dr. Munawar about distal radial interventions. Okay, I will invite Dr. Munawar to the discussion room. So, Dr. Kimene, I want to ask a few questions first. Yes. Yeah, because you know that you have started the radial intervention 30 years ago. Mm-hmm. You are the pioneer. I just want to have what you thought at that time to change from the femoral access to the radial one.
Kameranya tetap di tangan, coy, jangan diganti-ganti.
That is a very good point, and although it's over 30 years ago,
Okay.
My memory.
Dr. Yani, sorry, itu
in the early years of stenting, the patients were completely anticoagulated. You remember with heparin, Coumadin, Dextran, antiplatelet agents, everything that you could imagine. And we had to use 8 French catheters, and we had to puncture the femoral artery. And in that time, we were actually losing patients on major excess site bleeding, resulting in compromised hemodynamics, maybe stent thrombosis, multi-organ failure. And it's good to know that in the very early Binawaluya study, you remember the Binawaluya study? That was the Belgium-Netherlands stent study, comparing stenting and balloon angioplasty. There was in the interim analysis a 20% major excess bleeding, 1 in 5 patients.
Whoa, that's a huge number.
That is a huge number, and our center really coped with that problem, but it was not a local problem. It was a global problem with stenting. And just in 1989, that was just in that period, Dr. Lucien Campeau published actually quite a small paper on 100 patients who underwent transradial coronary angiography with 5 French catheters. And when I saw that paper, which was actually never intended to do interventions in that time because the devices were just too big to be compatible with the radial artery, but the connection that I made after having studied that paper was if you don't want a femoral bleeding, then don't puncture a femoral artery. And here only the tools were not available to do transradial interventions, and I had to wait until 1992 before the first 6 French catheters became available. And so that was actually the starting moment in August 14, I think, 1992, to do the first radial procedure. But it was driven by the major excess complications. And we had patients hospitalized for days before the sheath could be removed that time. you know, and then the patient really had to recover, and it was a very risky period. And the patients after radial access could have their sheath removed immediately after the procedure. They were walking around the same day, actually immediately after the procedure with a bandage on the wrist. So that was a very strong motivator to start radial.
Okay. Yeah, you can see the journey, the revolutionary.
Yes,
and the guideline now recommended the 1A recommendations.
It took a long time.
Took a long time. And now you encourage people intervention to do the distal radial. What is this?
Yes. Yeah. Before starting on distal radial, we now understand the importance of radial access. Radial access is just the safest way compared to femoral. That's what has been proven in many studies, and we all agree. It became a guideline. But the Achilles heel of radial access, especially after multiple uses, that the radial artery occludes. So then you are losing a very valuable entry site, and many patients come back for radial procedures nowadays, not only by cardiologists and a second, a third, a fourth, a fifth procedure, but also for interventional radiology, for neuro interventions. So the radial artery is actually becoming a very heavily used entry site. So if you are losing radial artery patency by multiple use, you are losing a very safe option for the patient. And I first saw distal radial access during a transradial meeting in Isfahan in Iran. And I saw Dr. Rogani doing this. And I was very surprised. I've never seen such an entry site before. And then I started to understand the advantages of distal radial access, which were just discussed in the background. So I thought the most important reason to go distal. There are many advantages, like I showed, but the most important one is that radial artery occlusion rates are lower. I think that's the holy grail of.
What do you think about this procedure?
Well, in the early years, there was nothing known actually about frequent access of a radial artery and the consequences of radial artery occlusions. And that was based on the paper of Professor Campo to do an Allen's test before. So that's what we routinely did. But in the course of time, we never saw any problems with or without the positive Allen's test. And although we recommended to do that during the live courses and here in the official papers, in practice, it was not frequently done anymore. So gradually in the course of time, we did not check for collateral collateral connections with between ulnar and radial. And now we also understand after arm function studies doesn't make any clinical difference if there is a positive or a negative test, and then the test itself is not very reliable as well.
So we didn't do it.
No. Are you still using it?
No.
Okay.
So about access in the hand, we have a radial, distal radial, ulnaris.
Yes.
How about this ulnaris?
Yeah, I think here the ulnar artery is a different animal. It runs deeper. It's more difficult to access, and what my theoretical fear was that there might be more risk for bleeding. And that if one is using the ulnar and the other is using a radial, and so there are no guidelines for that, it can happen that patients will lose both arteries, and in that case, that's something that is worrying me.
Okay.
Suppose you have an ulnar and a radial occlusion. Well, there still are connecting collaterals, but I don't know how strong they are and if that will impair hand function. But usually the only cases or the cases that are reported with digital ischemia are coming from distal embolization, not from proximal occlusions actually.
Okay.
But using ulnar as a default, sometimes you have to because there are no other options. I even have seen cases where the ulnar artery was used after harvesting the radial artery for bypasses. I think that's my personal opinion. I never did it because I think it's risky. But if you hear the lectures and the comments of ulnarists, how do you call them? We are radialists and you have ulnarists. Then the disadvantages are not very prominent. So,
okay. So, but you still have ulnarists for, options.
You have them, yeah. But in case the radial artery is occluded, I would not recommend to use an ulnar approach. I go to the other arm.
Oh, okay.
And even today, let's be fair, femoral approach now is different than 30 years ago. We have those micro puncture sets, ultrasound guided entry. So we have learned a lot from radial access. So I think today femoral puncture is a lot safer than 30 years ago.
Okay, thank you.
So we have 78-year-old gentleman with prolonged chest pain, with type 2 diabetes, and he had no previous myocardial infarction or intervention previously. And his lab result, there's a slight increase of NT-proBNP level with a normal LDL and A1C. And the renal function is good. And from the echo results showing that good ejection fraction. As you can see from the angio result, this patient had a progressive angina with critical stenosis and severely calcification in the distal left main up until ostial LAD and the circumflex. So let's proceed with the case. Good morning, everyone. Now I'm helping you to guide this recorded live case. My name is Dilara Sate, and as you can see here, that this case is started with left distal radial, but actually in this presentation, it is from right distal radial, so it doesn't matter which of which actually, but in these complex cases, we did left distal radial with IABP. In this case, we use a Prelude ideal with 6-7 French, with outer diameter is 6 French and the inner diameter is 7 French. So it doesn't matter if we use 7 French guiding to do a complex PCI. Because it's very slippery, we give a manual fixation. We take a derm patch as for IV access so that the procedure could be comfortable. Okay, so during this case, because left dominant system, we using IABP to reduce the ischemic burden, and we use 7 French with left distal radial access using a ideal. And then firstly, we use a workhorse wire to the circ. And then with a dual lumen catheter crusade, we trying to put our workhorse wire in the LAD. So this is a Sion wire. After several attempts, actually it's very difficult to get across the lesion because it's very tight on the ostial LAD. But with the dual lumen catheter, the Sion wire could cross eventually. But as you can see here, it's very difficult at the first attempt. But as you can see from the right side, the operator seems comfortable of doing using a left distal radial access from the left side of the patient and IABP from the right femoral artery. So the procedure will be more convenient both to the patient and also to the operator. And so as you can see from the angio that the Sion wire could cross the lesion eventually. And we proceed to our first strategy is to reduce the ischemic burden. We do a kissing balloon technique using 2O balloon in the both LAD and the circumflex. So we do a preparation beforehand just to make sure that the microcatheter could advance to the LAD because in this case, we want to use a primary rotablation and IVUS evaluation to have a better understanding in this case. So as you can see in the distal part, the vessels seems to be normal. However, in the mid part, we can see that some fiber calcification there with a calcium arc in this side is almost 270 degrees. And you can see it's a very severe and superficial calcification here. And if you can see more to the ostial of the LAD, we can see some nodule calcification. Right here is very critical and almost circumferential calcification in the ostial part of the LAD. Then we proceed to do an IVUS evaluation on the circ. As you see that the IVUS could not cross until the distal part, so we stop in the ostial part. As you can see, it's very critical and calcification, almost 360 degrees. So from here in the LAD, the IVUS calcium score is 4, and in the circ, the IVUS calcium score is 3. So from this IVUS result, we agreed to do some rotablation atherectomy for both vessels. Okay. So here we do a rotablation. As you can see, from the left distal radial, all of the devices that we are to advance, it seems very comfortable from the operator's point of view. So we want to exchange the wire using a single lumen catheter and then proceed to do a rotablation. As you can see that the rotablation, we can put in the leg part of the patient seems like from the femoral access. And we use 1.75 millimeter burr as our default in most of our cases. Particularly in this case, we also use 1.75 burr with 180,000 RPM. We do up until 5 times rotablation here. There's no problem during rotablation on the LAD. As you can see, the operator seems very comfortable doing rotablation. And then we proceed to do a rotablation in the proximal part of the left circumflex. See here, we also do the rotablation atherectomy with 1.75 burr in the circ. However, if we look closely on the hemodynamic, so after several attempts, we can see that there's a long pause on the ECG showing there's some disturbances there. So it's very uncommon to have a long pause after rotablation on the circ. However, this patient is having a left dominant system, so that is why we might have to put some temporary pacemaker to make the procedure going smoothly. So after several attempts, might be we decided to put another temporary pacemaker there. Previously, we not calculate this output, this outcome, but eventually we decided to do temporary pacemaker. So here, Dr. Munawar did a very fast temporary pacemaker implantation. And then after the patient stabilized with temporary pacemaker, we proceed the rotablation atherectomy quite smoothly without any problem. So in this part, maybe I have to, we do 14 times rotablation on the circ, and then we exchange again with the workhorse wire. And then after rotablation, the workhorse wire on the LAD going more easier. And this is the result after we do a rotational atherectomy in this patient. So we did another IVERS run showing that especially in the ostial part, we have some good burr mark here. And maybe we can see some reverberation in the ostial part, like this part with a good burr mark, showing acceptable result of rotablation. And in this particular case, we choose a Rotacut technique to have a aggressive lesion preparation because as we know that in this case, the IVUS calcium score is 4 on the LAD and the circ is 3. So we do stepwise lesion preparation using cutting balloon, starting with a 2.5 millimeter balloon up until 16 ATM in the LAD. And also we do preparation with a cutting balloon on the circ, stepwise starting from the 2.5 millimeter balloon. And then, so this is after small balloon, but we can see still there's some under expansion, but we hope that with a bigger balloon, the calcium deblocking and cracking is much, much better. With a cutting balloon, we have a control. Yeah. And then we do a 3.25 with millimeter cutting balloon on the LAD up until 22 ATM here, because we know exactly that it's very tight and calcified in the ostial. And follow on the circ, we use the same 3.25 millimeter balloon. So this is after Rotacut technique. And then we decided to do the DK crush technique in this left main complex lesion. So starting, because from the IVUS, the circ is bigger than the LAD, and also this is a left dominant system. The diameter on the circ is around 4, and then on the LAD is around 3. So we decided to do a DK crush using left main to the circ as the main vessel and LAD as a side branch. So that is why in this DK crush, firstly we put the stent on the LAD. So after we put the ostial part with 3.5 balloon, and then we crush it with 4.0 balloon in the circ. I keep this fast, and then we do recrossing on the proximal part of the LAD. And then we open with a small balloon, 2.0, and follow with a bigger balloon, 3.5 millimeter balloon. So this is the first kissing. And then we put this another stent on the main vessel from the left main to the circ. And then we did part in the left main. And then another recross in the distal or mid part of the stand on the LAD stand. And then followed with open the strut with 2.0 balloon. And then do some final kissing. This is bigger balloon, 3.5 balloon on the LAD, and followed with final kissing. And in this particular case, we did another stenting on the mid part, and then we did re-part on the left main using 5.0 millimeter NC balloon. And then I will skip this part because we did not the post evaluation, but this is the final result after 2 stand Dickey cross technique with Rota and Ivers, and using IABP and temporary pacemaker in this complex left main calcified lesion. So to make a clear understanding, this is what we did previously. For hemostatic device, we clean up the access. So even after some long hour of procedure, the patient felt very comfortable. As you can see that the hand position is in normal upright position, and then we pull for another 1 or 2 centimeter and put the preluding distal near to the axis, around 1-2 millimeter from the puncture site. So Dr. Kumene, who invented this design, which make the patient very comfortable even right after the sheet was taken off. And then we asked the patient to move the finger and the hand to make sure that it's very well fixated. And then we can see after 60 minutes of observation.
I think it's a beautiful demonstration, and it shows the value of distal radial, because I think this procedure took more than an hour.
Maybe few hours. 3 hours.
3 hours.
3 hours.
So yeah, this is actually the power of distal radial, because the patient is very comfortable. 3 hours rotating the arm in a nasty position, that is very stressful, and also for the operator who needs to work over the patient. So this is a very beautiful demonstration of left distal radial access, and it also demonstrates that you can do whatever you need to do with ultrasound, rotablator, kissing balloon techniques, crush technique. I'm very impressed. There are actually this case shows that there are actually no limitations. I am positively surprised that you removed the bandage after 1 hour, because this patient had a 7 French sheath in. It is a slender sheath.
Yeah.
So that in fact is comparable with the 6 French technique. Maybe this patient has, for a 3-hour procedure, some extra heparin on board. So the fact that you could safely remove the hemostasis device, which was tolerated well, is a very positive finding. So
usually for how long if you do a complex procedure to remove the
well, of course there are several. It is you shouldn't consider it as a sport to reduce compression time. You have to be fair. In some patients with let's say 4 or 5 French procedures, and the patients are not hypertensive, they are not overly anticoagulated, you can remove a bandage within an hour, but it's not clinically it's not very relevant to reduce hemostasis time to the shortest possible time, because it is convenient for the patient anyhow, this bandage. So for the patient it doesn't it isn't necessary to remove a bandage as fast as possible, because it will become riskier. the perspective of radial arterial occlusion, here 1 hour is short enough, you know, and you don't have this total compression. So there is no rush. But if you can, and you need to observe the patient after a complex procedure anyhow for some time. So that's why I think you should consider also other factors. If the patient is heavily anticoagulated, if the patient is hypertensive, if the patient is obese, keep it within safe limits, and that's a removal time between somewhere 1 and 2 hours. But in this situation, after 1 hour, it looks really beautiful. And that's also a general recommendation. After 1 hour, if you have relieved all air, you can leave the bandage.
Bandage?
Yeah, you can leave the hemostasis device on its place. Don't remove it. Because the patient is becoming more active, if the patient starts bleeding, you only need to reinflate. Because the bandage won't is not a burden to the patient. Actually, the presence of an empty bandage is not felt. It's not uncomfortable. So if you're not sure, if you think, well, maybe this is a bit on the early side for this patient, it looks well, you can just, for safety reasons, leave the bandage on its place. And if after an hour nothing has happened, or after half an hour, then you remove it.
Okay, so we just put the bandage there?
You leave it there. Because if you have a rebleeding, and sometimes that happens,
it can happen.
then you have to do the whole procedure again. And that is difficult because the sheath is already out, and to place a hemostasis bandage while a patient is bleeding is very difficult. So maybe you need to tape it more tightly. That's why I keep the bandage as it is. And
for how long usually?
Maybe half an hour or an hour. After you're sure that everything is okay, then you remove it before discharge or something.
Okay, thank you. So there is a question from the floor. Usually we puncture the distal radial for angiography, and then afterward we don't do directly PCI because a complex case we discuss with the patient. So tomorrow, whether we can use this site again for the repuncture, and how many times we can do repuncture in the same site?
Yeah, well, of course, that depends how the first time went. If the puncture was successful, hemostasis was okay, and the next day, or even after a few hours, you feel that the pulse is good and there's no hematoma, you can redo it. You know, it's not different compared to the forearm. But if you had a bleeding, or if you don't feel a good pulse because there is some subcutaneous hematoma, you can use with ultrasound and you can redo it again. And how many times? It's actually, I would say, not necessarily to limit the number of times, as long as your local inspection is okay. But if it's bloody, if it's painful, if it's hard to palpate, then I take another side to let this cure first.
As long as it's no pain, no hematoma, and you can palpate as well, you can do it.
If the patient feels okay, if it's not extremely painful, then you can redo it.
Okay. Very good. So, how about your experience? Because we are here, we are not using the guiding with the ultrasound to puncture. How about your experience? Whether we need to do an ultrasound for guiding the puncture? Or...
when I started Distal Radial, I didn't have ultrasound in the cath lab, and for me it was quite frustrating that although I felt a good pulse, I couldn't find a vessel with my needle. And like I said in my talk, the snuffbox is a delicate structure with the nerve and the vein and the periosteum of the scaphoid bone running there. So the tendons, you don't want to poke around too much in the same area.
Yes.
So first, I never remove the needle and reinsert it.
Oh,
so I keep the needle in,
Mm.
and then I try it in different angulations and from different directions to find the artery. But sometimes that didn't work, and that's quite frustrating. And then I really wished I had ultrasound. And later, ultrasound became available in the lab, and especially the handheld transducers without the whole ultrasound equipment. You have the software, you have the images on an iPad. It's all wireless, and I must say that really helps during the learning curve and in difficult situations, because I think if you do distal radial as a routine, now and then you will miss puncture. No matter how proficient you are, it just can happen. Maybe because the artery becomes spastic, or here there is some subcutaneous bleeding. You touch the artery, but the needle moved a little bit too much. Or even if you have good backflow and your wire doesn't go through. In all those situations, it's very nice to have ultrasound standby. So you only use it in case a straightforward puncture and access are not possible. And that became my routine. If I feel a good pulse, I do it blind. If I had some problems, I was very low with the threshold to use ultrasound.
So you have a bailout.
Yes, yes. And for teaching, it's excellent. If you need to teach fellows, if you need to teach colleagues, then it's good to see what you are doing. You can avoid, for example, a vein. If a vein runs over the radial artery, you can see it easy with ultrasound. By just compressing the transducer a bit, the artery will remain open, and the vein will occlude, and so you can avoid touching the vein, and that of course is important to avoid AV fistula or something in the snuffbox that you don't want to happen.
Have you found any complication of AV fistula in the distal radial?
I know there are case reports. I personally, I didn't have it in my experience. I had some pseudoaneurysm formation.
And how do you tackle that for the pseudoaneurysm?
Prolonged compression.
Only
and yes, and that might help there. But I also remember a case that only a surgical option was possible, because it kept on growing, and that was. But fortunately, that's very rare. That can happen to every artery that you puncture. It's not typically related to the snuffbox, but there are tips to treat it, also with prolonged inflation, or you leave the sheath longer in position and then remove it later. There are many options to deal with it conservatively, but in that particular patient, that didn't help.
Very nice, very nice. One or two more questions, because earlier you mentioned about when you puncture and then we put the wire, and it's better to have a image.
Yes.
To see the wire.
Yes. You
have any experience that is go to pulmonary artery and cause complications?
Yes. I actually have here some examples on my laptop where there was a good backflow. I smoothly introduced the wire, and then I couldn't advance the sheath. And I didn't understand what was happening, and so I used fluoroscopy, and I saw that the wire was not running into the forearm, but here into the hand. And I wondered why. That there must, the only option is that there must have been some side branch where the wire went into.
But you don't feel any resistance?
I didn't feel it, no.
Okay.
And because the wire is so thin and so flexible that the wire can easily go in, but the tip of your sheath, of course, won't, because it needs to make an angle, and the diameter restricts movement. So that's why I routinely use fluoroscopy. Fluoroscopy is only a matter of, it's not even a second. You see it immediately.
Yes.
And if you have ultrasound and you check, you see a sharp white shadow running into the forearm, you know it's okay. So it won't prolong the procedure. It's not cumbersome for no one, and you feel that you are safe. And you, of course, you don't want problems in the arch, because it's very important for finger perfusion. And so better safe than sorry. Then and I think that the risk of entering side branches is bigger if you puncture distal, because from the more distal you come in the distal radial artery, the more side branches you have.
So you speak in the snuffbox.
Yes,
so
not too far.
Yeah.
But I must admit that in my learning curve, and I review my cases, some were too distal.
Oh, okay.
I didn't think of that. I didn't care about that. But later I understood that that might have been the problem.
So you have maybe make a mark for the snuffbox.
Yeah, but I see that you are already making a mark.
You usually make a mark.
Yeah, and you can see it easily where the tendon runs. So actually, it's not necessary to mark it, but you can feel it quite easily. But when the patient has been covered up, and you don't have good sight on the snuffbox, so I think it's very bright idea to mark the puncture site before the procedure.
Yes,
very good idea.
So maybe my last question, maybe there is any difference of the age or sex between the easiness to access these distal radials? Maybe.
Yes, I think you mentioned two features, age and sex. I think a very fragile old lady might have more difficult access points everywhere. It can also be in the forearm, but distal artery is smaller. So I usually am very careful there, because also the tissue is very fragile, the skin is very fragile. So you have to be very careful with compression, with everything what you're doing. But the best option is to have a proper estimation of the distal radial artery diameter. In those situations where here in female patients where you don't feel a proper pulse, I use ultrasound.
Okay.
In all those situations where I'm not sure that it will be very easy, because a failed attempt to puncture might result in more problems. You might have some hematoma, you might have some spasms.
So it's more difficult.
Yeah, so better on beforehand, avoid problems, and you see what you are doing, where your needle is going. And don't force it. If you think, well, this is going to be impossible or very difficult, and you feel a better option in the other arm, in the radial artery, in the forearm, you better take the best and safest way.
Okay, thank you, Dr. Kimini. So before I close the sessions, maybe because distal radial is not popular yet here, not many centers did distal radial. Maybe you came here, you can encourage our interventionists to start the distal radial. Maybe you can give some tips, the closing statement.
Yes, I understand that there might be some reluctance to step out of the comfort zone. many people, and I don't, that's not criticism, but, you know, don't wait before evidence is there, because the technique is so young, and waiting for evidence can be an excuse to postpone a new experience. Yeah, there is enough evidence already. There are randomized studies. There are many courses. There are many publications. There are randomized studies, and like I said, everything points into the same direction. It's a safer technique and more comfortable technique, and you save radial arteries, so you can do it. And especially the diehard radialists who have done mostly radial in their careers. It's a newer generation, actually. Might have more problems in starting distal because they are so used in the forearm. But what I notice when training fellows or training people who are just never done radials before, like in the neurointerventional field or neuroradial or interventional radiology field, they cross over from the groin. They start directly in the snuffbox. They don't. You don't need to start as a fellow proximally. It's an unnecessary step, because if you are able to puncture the distal radial artery and you're trained by that, then a crossover to proximal will be very, very easy for you. It's not necessary to make this step first and then the other one, because the additional challenge in the last few centimeters is this extra curve that you have in the transition between the snuffbox and the palmar side of the wrist, and the slightly smaller diameter. And today we have better equipment, and my recommendation is just start, but don't start wild. I always recommend to have an experienced operator on your side as a proctor who can guide you through the procedure, who can intervene when something goes wrong or does not succeed. So be prepared, have a proctor before starting on your own, and have ultrasound available in your lab, and select the proper material. Maybe you have them already in your CAD lab. Maybe you have to change some products for easier access, just like in the old femoral days. We only had femoral needles and femoral sheaths, and later the materials became more refined. And today, I think everything is there to perform a safe and successful procedure. So that would be my recommendation. There's enough technology, there's enough knowledge, and there are enough training opportunities. So use them, but make that step, I would say, because it will become default. That's my I'm convinced that this will become the default strategy.
Okay, thank you very much, Dr. Kimene, for your presentation, for your advice, and also tips, and encouraging us as an interventionist in Indonesia to make distal radial more popular.
My pleasure. Thank you.
So I just to make some summary about this morning presentation and live cases. We see that distal radial have many advantages. First, the radial occlusion, artery occlusion is lower than radial interventions, and also the bleeding and hematomas is less, and also is convenience for operator. And about the crossover, I think it's not a problem here. So yeah, we still use the hands for the interventions here. So what I get from here, if you do a distal radial, you only have a gain, not lose. Because you just, if you cannot do this, you just change to another side. So you have another options. So it's not a lose, but it's only gain.
I completely agree. Nothing to lose, only to gain.
Nothing to lose, only gain. Yes, good remarks. Yeah, and I would thank you for all the speaker, Dr. Kimene, Dr. Munawar, and all the staff in the background that have this webinar camps fluently. Yeah, even though even though there's some small problem, but it's take up good. And I also want to thank our sponsor, Merit Medical, that make this webinar a success, and also they create very useful hemostatic tools that helps when we do distal radial interventions. Okay, thank you everybody. We closed earlier this morning, and see you again in our next webinar next month. See you. Bye-bye.